We are lucky today to have Dave Vassilaros from Capital Blue Cross. Dave is the Director of Healthcare Reform and Regulatory Affairs for Capital Blue Cross in Harrisburg. I don't know how you fit that on your business card. Dave also serves as the company's liaison to the Pennsylvania Insurance Department for a wide range of regulatory issues and policies. Dave also serves on the Employee Benefits Committee for the U.S. Chamber of Commerce. Before coming in Capital Blue Cross, Dave worked at a private law firm. So Dave is very good at taking complex issues and putting them in plain English. And with that being said, let's welcome Dave Vassilaros from Capital Blue Cross. There is a clicker if you want to walk around. Sorry, thanks. All right. Can I steal that thing? This thing here, yeah. Thank you. All right, so I'm going to try to keep this in one spot because I'm half Greek and half Texan, so I talk a lot and I wave my hands around. So it's hard to do that when I'm holding something. So first of all, thanks for having me, Todd and Bob and everybody. I'm really glad to be here. Originally, I thought that PPACA was kind of like the Full Employment Act for lawyers and consultants, and I want to add CPAs to that list. That was quite daunting. But right before I got up here, Vince leaned over and he said to me, hey, listen, I'll handle all the hard questions. So we're gonna pass any of those hard questions that we just heard from our tax friends over to Vince in a few minutes. So look, this is a big thing. Okay, and I like to start off by talking about healthcare reform in terms of it being the new normal. The reason I like to do this is because when they passed this law, March 23rd, 2010, they handed everyone involved with the health insurance industry a new business model, right? It's about 2,000 pages, and with 15,000 pages of regulations plus still to come. And they said, here's how you're going to do business. What you've done for the last 75 years is now over. Congratulations and good luck. That was what they did. So when we talk about it, I like to talk about it in being, this is not tweaks around the edges. It's kind of like, well, business as usual, but we've got to comply with some new things and we've got to add some new reporting and some new auditing. That is not the case, right? This is a sea change of how insurance works in this country. And everyone is going to be touched by this who deals with insurance, either uses it, sells it, helps with it, whatever. So before I jump in, I want to point out just a couple of things that I heard from Tony and Milan. And that is, first off, the W-2 reporting. They mentioned that you have to start reporting the value of your benefits on your W-2. Recent survey came out, 62% of employees have no idea how much their employer contributes or pays for their health insurance. 62% have no idea. Those that did, less than half were confident in the number that they put down. Many of them put $500 or less. That's per month. Okay, so we're dealing with a massive gap in knowledge about how this stuff works. The W-2, I am not, and I'm going to say this right up front, having read the law, having lived the law, having implemented the law, having read all the, okay, that's a lie. Not all the regulations, nearly all of the regulations. I can tell you that there are things I'm not a huge fan of. But what I can tell you is, whatever that comes out of this that helps educate people about how insurance works, what it is, what it isn't, how much it costs, what drives those costs, those are good things. So I'll just throw that out. That's my little comment on the W-2. Second, the comment, the last thing we talked about was that Cadillac tax in 2018. I just want to point out, it doesn't hit just insurance companies who offer plans that hit those richness benefits levels. It's also self-insured companies, right? So large groups, large companies who are paying their own insurance claims and can hit those as well, so they'll be subject to that tax. So it's all of us are in it together. All right, Here we go, I think. He said this would work. It's not working. All right, we're just going to do the old-fashioned way. So they asked me to talk about some of the stuff from the carrier's perspective. I'm going to try to do that. I'm going to try not to be too nerdy. I am a healthcare reform nerd. I don't back off of that. I'm kind of proud. And I walk around work, and as you can hear from the first presentation, when we start to talk about this stuff, people kind of like, oh man, is he really gonna say that stuff again? I'm kind of the rain cloud at work. They see me coming to a meeting, and they're like, oh. So I've gotten used to that. It's okay now. But I want to talk about this stuff from a carrier's perspective, if possible. First of all, we talked about, well, it was mentioned, the exchange, right? Raise your hand if you can tell me in 15 seconds or less what the exchange is. Come on. Someone. No one? Vince? Kidding, Vince knows. So look, an exchange. You ready? It's where you buy stuff online. That's what it is. That's all it is. An exchange is where you buy health insurance online, right? This is like ground-shaking stuff. Have you bought stuff online? Raise your hand. Bought stuff online? Okay, that's an exchange. It has three parts for this government-run exchange. There are three parts, okay? First part, there's going to be a web store, and that's what we're talking about. That's where people go in and they shop and they compare plans and they hit buy and whatever, right? That's the place that people are going to see and interact with. Second part are all the rules and you can't really see that, can you? It says rules and regs. It's all the rules and regulations that go on that regulate who gets to sell stuff on the exchange. So Amazon has a set of rules and procedures and policies to allow vendors and individuals to sell stuff on their website. This will operate the same way, just worse. So because you're going to have the insurance department is going to be regulating insurance companies who want to sell their products on the exchange. That means they're going to have to look at what the products, what they are, how affordable they are, look at their networks, look at their transparency, look at their customer satisfaction, et cetera, et cetera. All of these rules on the front end or on the back end for insurance companies to sell. There's going to be lots of rules for people who want to buy. Now, anyone can buy on the exchange, okay? But if you want federal subsidy dollars, then you have to be eligible for them. So there's lots of rules, and you have to go through that. So there's rules and regs. And finally, my favorite topic. This says data platform, if you can't see it. I affectionately refer to that as the unicorn. Anyone seen a unicorn? We all know what a unicorn is, though, right? And they make us feel good. You know, a mythical creature doesn't exist, has superpowers. I'm sure I'm being facetious, and this is gonna be fine. But what it does is it's gonna connect using the internet to connect all of the state agencies. So you got Treasury, you're gonna have Department of Insurance, Department of Health, DPW, probably the DMV. You're going to connect all of their systems, right, into a little thing, and then that thing is going to connect to another thing where the federal government's agencies are all going to talk to each other. Listen to this lineup: HHS, CMS runs Medicare, IRS, Treasury, Homeland Security, Department of State, Interior. And they're going to all talk to each other and exchange data. And then, so you're going to put all their stuff into one hub and all the state stuff into the other hub, and they're going to talk to each other real time by October. Now, to be fair, it's October of next year. So hence unicorn, right? I think they'll get something up. They'll get something built. I'm confident in that. They have the resources, and they're certainly pouring the money into it. And they're very smart people working on it. But these are huge problems. I saw a schematic once of the federal government's IT systems. Right. So they're going to take all of those and standardize how they communicate and what they send back and forth. And they don't even talk to each other on the phone, right? And they're going to do it. So I'm sure something's going to happen. It's not going to be pretty, and it's certainly not going to be real time at the beginning. So those are the three parts that are going to make this exchange work. Remember, but for us users, the exchange is just a place where we buy stuff online. So how many in this room can explain what an exchange is in 15 seconds or less now? Raise your hand. Yeah, there you go. See? Super. I should just stop. Vince, you ready?
Let's go.
All right, super. So this is just for fun. This is a just for fun slide. You remember the rules and regs, little red ball at the bottom? Okay, and those are just the ones that were in the law. That doesn't include the hundreds of pages of regulations that we've gotten since then and the hundreds more that we haven't gotten yet. So these are all the things that either the state or the carriers are going to have to do, insurance companies are going to have to do to sell or buy on the exchange. All right, onward we go. So the next part, what is the exchange really going to do? What's the impact it's going to have? There's a couple things. So this is Newton's Cradle. Can you see the little strings? Does everyone know what that means? All right, Newton's Cradle, you know the balls, you drop the one, it hits the other, and you can do them in different. My dad's a scientist, so he always brings this stuff over, and I have 4 little boys to play with the grandkids. Invariably, they break it. Shocker, right? And he gets angry, he takes it home, he fixes it, and brings it back. Right, so that's his Newton's Cradle. And that little red ball on the end is the exchange. So they're about to drop that exchange into the marketplace. A couple things are going to happen. First, the government becomes a direct competitor with insurance companies and agencies. And the way that is because they are now going to enter kind of the mind share of people who buy insurance. Okay, hang with me now. If someone gets Medicaid, does anyone think, well, Medicaid, I wonder who the carrier is? No. People say, well, Medicaid, that's a government program. I know I have to go to the government. I'll fill out my forms. They'll tell me where I need to go, and the benefits will come, and I guess I'll pick from a list of carriers. They say they all have to offer the same thing, so I'm sure it's fine. Right? That's what I'm talking about, mind share. So now the federal government and state government in some cases will start to compete for the mind share of commercial customers. Because now we're going to say, well, you can buy yours on the exchange run by the government at the government website. They'll buy our products because the government's not offering products, but they'll go through the government process. So that's one impact. And so you'll see communication and you'll see marketing campaigns and all of that. Second thing, there's what I call going to be the retailing of health insurance. Now, for group insurance, it's typically wholesale. I mean, we sell to an employer who has a certain number of employees, right? It's kind of a wholesale prospect. The exchanges are going to introduce kind of an acceleration of the retailing of health insurance in that it's going to start to break down more and more of the association we make in our head between health insurance and employer, right? You're going to have a lot of people who are going to fall in those penalty areas that were talked about before. Let's say that they make $20,000 a year. The coverage that the employer offers is going to be more than 9.5% of their household income. So it's going to be unaffordable for them. They're going to go to the exchange and buy a policy, an individual policy. And when individuals start to shop for things in a retail environment, they expect different stuff, right? They expect to be treated differently. A retail environment is different. You walk into Costco and you walk into Neiman Marcus, right? Very different. People expect different levels of service when they're as a retailer. So that's going to be the next thing. You're going to see things, a lot more tools that are targeting individuals, things that are going to help them be better consumers of healthcare, to know more about insurance, to know more about how high a quality outcomes the providers, the doctors and hospitals give in their areas. So they're going to be able to shop, right? More shopping, more information, more transparency. Finally, you're going to see growth. But this is growth with a caveat. I think the last time I hung out with you, we talked about exchanges in context of cars and car dealers. I don't know if you remember. It was really memorable, I promise. The idea was, you know, the story is health insurers are going to love this because they're going to have all these new customers. Okay, true, with some asterisk. But let's talk about those customers. I'm going to put it in terms of cars again. That's like saying, hey, let's say that PPACA was really a everyone has to buy a car law. And you go and the car manufacturers and the car dealers say, hey, this is going to be great. We're going to have all these new customers. Except that they're going to be forced. Do you remember that slide with all the little red boxes with the rules? Right? Now imagine every one of those rules is a feature on the car that you have to build and in order to sell to these new customers. In other words, I can only sell a car that has backup camera, at least a 7-inch screen that can do all my nav and everything else. It has the Bliss system that warns you if there's someone in your blind spot, that has side and rear and front airbags, that has you know, air suspension, that has, so I'm just listing all the things that are in my neighbor's car. And so he has all these things. And now you can only sell that car to all these new customers. Well, the first question I would ask is, how much can I charge? Right? Because all these things cost money. You know, if I get to add, there's a reason why not every car has a 7-inch touch screen in it that comes up and down, you know, automatically. You know, there's a reason. It's because it's expensive. So the answer from the government would be, well, we don't really care how much it costs you, because this is how much you can charge. And so the car dealer is going to go back and the manufacturer is going to go back to all their parts suppliers and say, hey, we need you to bring your parts prices down. And they're going to say, why? You have to sell cars with my stuff in it. And they're going to say, well, that's a good point. So then they're going to try to sell cars with all this new stuff in it to people who have to buy them. That sounds good, right? Well, every one of those customers now costs more than they would have before. So let's go back to health insurance. Yes, there's going to be growth. In Pennsylvania, there's about 1 million uninsured citizens of the Commonwealth. So that's 1 million new customers, right? Assuming they all buy insurance the way they're supposed to, by the law. Each one of them is going to cost more. The benefits are going to be richer. The underlying costs of care with the doctors and the hospitals and the drugs and the robots who do surgery and all that stuff, those are going to keep going up. But we are going to, as insurers, are going to have to sell something at certain prices. So it's, yes, there's going to be growth. It's going to be expensive growth. And so you would ask, if any of you are, you know, running your own businesses, growth isn't always where it's at if it costs too much, right? Go to the next one. So let's talk about, this kind of gets at that car analogy as to what has to be sold in the car, right? Every insurance policy, oh dang, you can't see it. On the little red guy it says price. I should put them in white. So every insurance policy is sold in the exchange, for example, is going to look pretty much the same. It has to include a list of benefits called the essential health benefits. That's determined by, someone guess? Government. So the government's going to tell us what every policy has to include. That's going to be the list of essential benefits. Every policy sold in the exchange will have them. They will be the same, okay? You see our little stars down there. You got a bronze one, a silver one, and a gold one. There should be a platinum one, but platinum looks exactly like silver, so whatever. So there's a platinum one over there on the right you can't see. These are going to be the metal levels. So every policy is going to have the same benefits, cover the same things, but the metal levels get to determine what the employer or what the customer's cost sharing is going to be. So at a bronze level, the plan only has to cover 60% of the cost of the plan, right? So that leaves 40% to be covered by the customer. A silver will be 70%. Gold, 80, platinum, 90. Same benefit structure, you know, same coverage, just different how much you're going to pay for it out of your own pocket. Obviously, the bronze are going to be the cheapest. Right? They'll have higher deductibles, higher co-pays, higher co-insurance, but they'll have the lowest premiums. You're going to see a lot of young people, healthy people who have to buy insurance because the tax, or they feel like they're law-abiding. We're going to get the cheapest coverage. Same benefits. The impact of this is, as you can tell from the slide, they all kind of look the same, right? So when you go to buy toilet paper, can I say toilet paper? All right, when you go to buy toilet paper, I know there's differences, right? There's like a different ply and different, I don't know, really, honestly, my wife buys toilet paper, but I know there's differences. But really, are they that different, right? They're kind of the same thing. So you buy them based on whatever. You're the ones you grew up with, the ones that have the coolest, cutest little teddy bear on them, or whatever, the big manly brawn guy, right? So whatever. You buy these things, it's pretty close in price, and they do the same thing. And the companies try to change them around, brand them a little, and sell their benefits. Well, that's going to be the new world that health insurance is going to be selling in. Policies are going to be very similar. Pricing is going to vary a little, of course. You got the same gold, silver, bronze, platinum thing. So how do you stand out? My opinion is, on the exchange, you're going to stand out by having the lowest price. This is a new world in the insurance industry. Insurance, it's a very complicated thing, and I think there's a lot of things. I'm not going to plug us, but as I've been now in this industry for 4 years, it's complicated, and insurance companies do a whole lot more than just paying claims. Right? There's a lot of value there, and when you're in a commoditized marketplace where everything's pretty much the same, you have to then find a way to compete on other little tiny things or its price. And in the exchange, what we found in our research is there's going to be a huge number of these people going to buy insurance that will change insurance companies for a $2 a month difference the next year, right? This year, I'm just getting bronze because I have to get it, and that way the IRS doesn't send me a nasty gram. But I don't really care because I don't really use it. So I'll just go with the cheapest thing next year, right? So anyone trying to sell anything, that's not a great environment to compete in. Watch for that. That'll be a big thing. Let's talk about counting the cost. It's a ball and chain with a dollar sign, in case you can't see what that is. This is my chance, and I don't often get to do this when we talk to groups because we're usually talking about you. So for just a few minutes, I want to talk about the insurance industry, insurance companies in particular, and the pressures that we're going to be feeling financially. First thing, rate review. It was probably not known by many people outside of the insurance industry and the insurance department and the legislators, but last year there was a new law that was passed that gives the insurance department the ability to review all of our rate increases, even in our commercial group business. That's never been the case before. They've always been able to review our rate increases for HMO products, special care, I think, so kind of a limited group. But now all insurance companies in Pennsylvania, health insurance, can have all of their rates reviewed and rejected possibly by the insurance department. MLR essentially limits what health insurance companies can have keep in a good year. Some would describe it, I think this is a little cynical, but some would describe it as you don't get a good year. You only get a break-even year or a bad year, right? So I still think there's room. But either way, if I only spend, say, 75 cents of every premium dollar instead of 80 on my small group business, I will send 5 cents back, aggregated in cash to the employer group or the individuals, right? So you don't have that rainy day fund, you don't reinvest as much and things like that. So they kind of get you on the front end with rate review, back end on MLR. There's the compliance costs. And this is a little bit of woe is me. Okay, I admit it. I'm sorry. I never get to whine about this stuff. But the bottom line is it's a lot of work, right? Those 2,000 pages plus 15,000 pages of regulations, 90% of those deal with me, right, and what we do. So we have probably 120 people who are working on projects at any given time at our company. This is over and above their regular day jobs. We've hired people. There's lawyers. There's compliance. There's all this. It's a huge personnel effort. Okay, wah, but all right, there it is. Finally, the excise tax. This is one tax that wasn't covered in the previous presentation. The excise tax is, in the first year, $8 billion that the insurance industry is going to pay to help subsidize the cost of the federal government giving those subsidies through the exchange, right, to help pay for the individuals who need the subsidies. Capital Blue Cross has estimated it'll be about $35 million in the first year, and then rising to about $50 million by 2016, and then it rises forever after that. That's bottom line, pull that right out. It's going to be, we've looked at it nationally, it looks like it's anywhere from 2 to 2.5% back through your rates. This is how much that's, the impact on rates that's going to have, 2 to 2.5%. This is a big expense. Right? This is now a new cost of doing business. Not every company in the country, there's a lot of smaller health insurers out there, or people who sell health insurance as one of their lines, are going to be able to swallow that kind of a hit on their bottom line. So you're going to have insurance companies looking at different ways of dealing with things when they have a huge chunk of money that's going to come out. So these are the big kind of cost issues on the insurer's side. Why does that matter? Why do you guys care? Because any costs that we have, we need to pass through to our customers, just like every business. When you get your cable bill and you're like, when I signed up, this said $99 a month, and it comes to 120, and you look down at the bottom, and then you click on the little expand thing, and it brings up 8 lines of taxes and fees. That's what you're doing. You're paying, we customers are paying for the cable company's taxes that the federal government puts on them. It's going to operate very similarly for health insurers. I'm just telling you, that stuff's going to get passed through. Because anyways. So counting the cost, it's a big cost. You're going to see it. We're all going to see it. So I won't get into the fact that this was an Orwellian name of a law, Affordable Care Act. But okay, we'll move on. It's not often you get to drop Orwellian into a health insurance. All right, so this is my last slide, and I don't have my paper here, so I'll just have to go from the top of my head. So the cracks and spirals. This is kind of where we get to take a step back and say, what's this going to do on a macro scale, right? The Patient Protection and Affordable Care Act had a single goal. Forget the rhetoric. It had a single goal, and that was to expand coverage in this country, to expand so that every person, every legal resident of this country had access to insurance, had insurance. That was the goal, right? It followed the Massachusetts law that was passed in 2006, whose goal was also stated as getting everybody covered. Great. There's a couple problems with how the law tried to execute that. There was talk about this tax, right? The penalty if you don't get insurance, it's the $95 or the 1% or the $325 or the $695. The problem with that is there's very weak enforcement, right? Normally, if you don't pay your taxes, then you get nasty grams and you get investigated and you have all sorts of problems, and they come and get you and they get their money. That's not the case for this one. The only way that they can enforce this tax is if you are going to be due a tax refund, in which case they will garnish that refund and withhold whatever the penalty or the tax amount was. So immediately everyone in this room should be thinking, boy, I should call Kincannon Miller and see how I can reduce my tax refund, because that'll save me a lot of money. Okay? So if you're not due a tax refund, there is effectively no penalty for not having health insurance. Okay? So generally speaking, this penalty, this new tax, is targeting a demographic of our citizenry that is least capable of giving up extra money to the government. This is a middle to lower middle class tax. That's all there is to it. Anyone who's going to get these tax refunds, they're going to be the ones who get hit the hardest with this penalty. So you're going to change your deductions. You're going to change how much you give in charitable. You're going to do all sorts of things. If you don't want to pay that $500 to $600, $700 a month for insurance, you're just going to change it, and you're going to save a lot of money. So there's not a lot of enforcement. And so coverage, I think, is going to fall into the cracks a little bit here. The other thing is, and I'll stop with this, is kind of the real issue. Okay, remember what PPACA's goal was? Number one goal was to expand coverage, cover the uninsured. Their number two goal was not expand access for the uninsured. Access in this meaning being how many doctors are there that can see 30 million new patients. Okay, I'll throw this out for you for your digestion. Average age of primary care physicians in Pennsylvania is, anyone want to guess? No, not 70. That's 59. It's very close. 59. Okay, let me ask you, and if you have physician friends, primary care physician friends, ask them what they're going to do after 2014. Just in Pennsylvania, there's going to be 1 million new people with health insurance, many of them on Medicaid, by the way. They're going to say, you're going to say, what are you going to do? You're going to take your portion of those new members, maybe 400 new patients, get on that wheel, run that hamster wheel just a little faster, see 45 instead of 40 patients a day, make the same amount of money? The answer is going to be, well, actually, my boat looks really good. Or my garden is really beckoning me, right? Because we have a problem. Insurance is one problem. And look, the health insurance industry is not perfect. There are problems there. But the bigger problem is we don't have enough doctors. I asked around in where I live out in Harrisburg area, a friend of mine who's a doctor, I said, how many friends of yours are taking new patients in this area? 1. And I'm guaranteeing you he wasn't taking 100 new patients. He was probably taking 12 new patients. Okay? So once everyone has coverage, which is a good thing, and it aligns with Capital Blue Cross's mission for 75 years, expanding coverage for everyone. That's what we've always tried to do. You have to balance it out with what are they going to use that card for, right? And are they going to be able to afford the health care that they need and want? I am saying that the law as it stands doesn't really address that. The cost of care will continue to go up, and it's too hard and too long to train new doctors. There are new drugs that are awesome and miraculous that cost a fortune. There's lasers and robots and stuff we thought about when we were kids and we watched the Jetsons. All that stuff raises the cost of care. That we have to get at somehow. And I'll throw this last one in. I think all of us, probably aren't in as good a habit of being good consumers of healthcare as we could be. We could learn a little more. We could all eat a little better. We could all exercise just a little more. All of us could own our health just a little more. And I think you pair that up with more coverage, I think you're going to get a lot better results than if you don't. So those are kind of my slides and my comments, and I guess at this point I'll turn it over. Thanks, everybody.